Good afternoon. On behalf of Acevedo Consulting, we thank you for joining us today for our complimentary webinar, 2017 Medicare Changes. Please note we have several handouts for today. You can get our handouts through the Handouts tab on the right-hand side of your screen. Going to the Handouts tab, and you can click on the document and print it out. Also, at the end of the presentation, there is a short survey that takes just 1 or 2 minutes to complete. We graciously appreciate your input and would appreciate just a couple of minutes of your feedback. Today's presenter is Jean Acevedo. Also, please note, we set aside some time at the end of the webinar to address questions. Please submit your questions throughout the webinar in the questions box in the taskbar on the right-hand side of your screen. I will now turn the webinar over to Jean to begin the presentation.
Thank you, Mary Catherine. Good afternoon, everyone. So one of the things that I'm going to say, in addition to the normal little disclaimer that lets you know that, hey, things are probably going to change between now and when you start doing implementing some of these services or new rules come 2017, is that, as usual for this topic, I have an awful lot of material to cover. In fact, I wasn't able to pull everything out of the final fee schedule rule that I probably would have liked to make sure that I hit the probably most important areas for probably everybody on the call, at least a little bit of something for everybody, right? So should it be that we get to 1:30 and we haven't gone to questions, I would urge you all to be typing in any questions in the chat or questions box as I go along, and if indeed we run out of time, because I do want to make sure that I go over everything, that all the material that's here. We'll just make sure that for everybody that's registered, we send the questions and written responses back to everybody. So when I do the Medicare update talk for the year, I really need to stress, when I'm doing it before the next year has started, the disclaimer. There are several policy changes for 2017, new codes that can be billed, etc. And I haven't seen any MedLearn Matters articles, transmittals to the contractors, the MACs, etc. So you can be guaranteed that some of these new benefits and changes in how the Medicare program is looking at services will undergo some further interpretation. So please keep that in mind, because something tells me that by January or February, some of what I'm going to tell you today is probably going to be tweaked a little bit as the feds, those folks at CMS, recognize that maybe we weren't as clear or explicit regarding a specific topic as they would have liked. So bear with that. So here's pretty much what I'm going to go over today. For anybody who does major surgical procedures, those with a 10-day global period or a 90-day global period, you have, depending on what state you're in, I should say, and the size of your practice, you will have some more reporting requirements, new reporting requirements come January. If you're primary care or any specialty that is involved in care management and more of a patient-centered service, so whether it's family practice, internal medicine, palliative care, rheumatology, cardiology, etc., there are some phenomenal changes for you guys, especially if you happen to have adopted some of the more, what's the word I want to use, the services that Medicare is clearly starting to pay for, recognizing that reimbursing physicians for their cognitive abilities with the patients can indeed prevent some higher costly procedures such as services such as hospital admissions. Anybody who is a physical or occupational therapist or employs any of them, there are a whole new set of therapy evaluation codes for 2017. If you're doing x-rays in your office and you're still on film, there are some payment reductions. And then the billing for dually eligible Medicare and Medicaid beneficiaries is nothing new, And when I get to it, I'll tell you, and I'm going to say it now, but I think it bears repeating because CMS sure as heck is repeating it, that there is a prohibition about billing these individuals, and it must be no less than, wow, probably 4 or 5 times in 2016 that in varying ways the Medicare program has tried to get that message across. And then for anybody who might have any providers in their organization that are not enrolled in traditional Medicare because they only see Medicare patients in Medicare Advantage plans, you're going to see a change there as well. So let's get started. I'm going to start off with the surgical folks. There are some data collection that starts January 1. So what is this all about? A year or two ago, the Medicare program tried to add to the physician fee schedule rule the ability to have surgeons report their pre- and post-op services because they really felt that the Medicare program, probably weren't paying appropriately with the global package that includes the procedure itself and that pre-op visit if it's the day before or day of surgery and the post-op visits. And they were kind of looking at unbundling the services. Well, appropriately so, the surgical community was up in arms. And in MACRA, I know we all think about that as only for the quality payment program, but in MACRA, which was a broader law, the Congress actually told CMS, no, don't even think about unbundling surgical global packages until you do a study. And they mandated certain things, which are going to start in 2017. And if you think about it, the surgical package as we know it today probably is not an accurate payment methodology. There's no way in today's world for the Medicare program to know not only how many visits are actually provided as technology has changed, but what is the intensity of those services, right? And then since I'm in sunny South Florida, where plenty of folks post-surgery come in the winter time, maybe and very often within that 90-day global period, and the doctors they're seeing here for their post-op care are billing appropriately so, their evaluation and management codes, well, that means that Medicare has paid the global package to the surgeon, but yet that surgeon is not providing all of the post-op codes, and they're paying again, right, for another physician or non-physician practitioner to provide some of that post-op care. So if you stop and think about it, it's really clear that that surgical package approach isn't really working. And of course, the devil is in the details, as with any policy changes. So before CMS actually gets to transforming that methodology of payment, they're going to have to collect some data. And as I mentioned, this comes out of MACRA, which requires the CMS to develop through rulemaking, and that was the Medicare Physician Fee Schedule Rule, a process to gather information needed to value surgical services from a representative sample of physicians, and that they begin no later than January 1. So they're going to begin January 1. Now CMS did go on a listening tour. I know I was actually on a call with some of the national specialty societies several months ago as they tried to figure out what was the best way to do this. And they've come up with what is probably the simplest of all of the recommendations that the American College of Surgeons and all of the subspecialty surgical organizations, orthopedics, etc., recommended, in all honesty. They had originally published a study that the RAND Corporation did for CMS that was creating new G codes that surgeons would have had to have used, and they were time-based codes, etc. In fact, that's what was in the proposed 2017 Physician Fee Schedule Rule. But again, the physician community, appropriately so, screamed with their comments, so CMS rolled that back. But they do say, quote, there is a critical need to obtain complete information if we are to value global packages accurately and in a way that preserves relativity across the fee schedule. So what the heck is that going to mean for anybody who performs and bills services that have a 10-day global period or a 90-day? Hopefully all of those folks are already, at least for internal purposes, excuse me, coding their post-op visits with CPT code 99024. Well, this is going to be the code that will go on claims for reporting post-op services. They're not going to require it for pre-op visits, just for post-op visits, which is a change from the proposed rule. It's not for every CPT code that has a 10 or 90-day global period. The final rule states that reporting will be required only for services related to codes that are reported annually by more than 100 practitioners and that are reported more than 10,000 times, or that the Medicare program pays out at least $10 million a year. So it's not going to be those little onesie-twosie little surgical procedures that are rarely done. Mandatory requirements to report will be effective for procedures that fall under these categories that are furnished on or after July 1, but they are encouraging everybody to begin reporting come January 1. Right? In fact, I would encourage you all to start getting in the habit of reporting 99024 where you're supposed to be as of January, so that you're not stuck with any non-compliance by the time you get to July, right? It's going to take a while to create that new habit. And I would say new habit even for those folks who are reporting 99024 routinely, for those patients who come to their office for post-op, because as I've asked surgeons since CMS has been toying with this idea of having some reporting for post-op care, it's hard to find a doctor who will tell me that they actually do bring that information back for reporting, at least internally, of a post-op visit while the patient is still in the facility, whether it's the day of the procedure or a subsequent day. So keep that in mind. So I would mention that not every state and not every doctor. So if you're in a group with 10 or more practitioners, now CMS uses language very carefully. You notice that it's practitioner, not physicians. So if there are 5 doctors and 5 PAs, we have 10 practitioners, right? So think about the eligible practitioners that you need to count to know whether the size of your group for reporting PQRS. That's probably a good way to look at it. And so if there are 10 or more of you and you practice in the 9 states listed, shocker that my state of Florida has been chosen, she said facetiously. If you're in a group of 10 or more practitioners, you can tune out for a few minutes, and even if you are, but you're in one of the other 41 states, you can also take a little mental breather, right? And however, if you're not in those 9 states or you are in a smaller group, the CMS does encourage you to report if you feel that it's possible. And I will tell you that if it was me, even if I was solo, I would be reporting. Hopefully I've been reporting 99024 fairly routinely anyway for my own internal purposes. And knowing that what the result of this data collection is going to be is clearly the possibility of a payment change, I'd want to make sure that CMS had as much information as possible. Now, that information is limited because even CMS says, quote, since CPT code 99024 will only provide data on the number of visits and no data on the level or resources used in furnishing the visit, we believe this is only the first step in gathering the data required. So there's going to be more. In fact, there's another thing that's going to start in 2017. Because MACRA, if you remember a few slides ago, said that what CMS needed to capture was not only the number, but the level of visits, the intensity, what are the resources needed, etc. Without that, it's not an accurate computation as to how to reimburse a physician for a particular procedure. So they did look at keeping the numbers where they are, right, that if it's more than 10,000 times, $10 million annually, etc. When they looked at how many codes and how many practitioners that that would entail. They said that it would be about 260 surgical codes and account for about 87% of all of the 10 or 90-day global services that are billed to Medicare. So it really is, sounds like a small number, but it really is a large, statistically valid sample, as the government would like to say. So which codes, right? So we know the size of your practice, the number of times a code has to be developed, we know the code you're reporting, you'd put it on a claim. So for 2017, they're going to use data from, claims data from calendar year 2014 to determine the list of codes. So be on the lookout for that list if you're a surgeon or another procedural specialty that performs and bills codes that have a 10-day global. They'll update that list as the years go on because they're going to have to be collecting data for more than 1 year before they even sit down to try to analyze it and figure out what they may or may not do to tweak the surgical package payment that we have now. And as codes are deleted from 1 year, they will automatically add the codes that have been added to the CPT book or the HCPCS book, right, that would have been the codes in the year for the prior codes. For any of you who are in a teaching physician situation, and because we have now a couple of really good medical schools here in South Florida, including in Palm Beach County with FAU, there are more and more community physicians in my state that find themselves as the attending physician or teaching physician, know that they also need to report the 99024, but only when it meets all of the excuse me, teaching requirement visits. And then when it comes to excluding practices with who have fewer than 10 practitioners, they figure that about 45% of all surgical/procedural clinicians won't be required to report. So, you know, those of you on the call, on this webinar, you know whether or not this is going to apply to you. So they figure that there's claims-based data collection for the 9 states using CPT code. I'm sorry, to summarize, it's claims-based collection for the data collection for 9 states for practices that have 10 or more practitioners, only for post-op visits, so not pre-op, although I would encourage you to be collecting that data with a 99024 anyway. It will go on claims. There'll be more information to follow because I think about whether or not the system, Medicare system, your claims processing system, will allow you to submit a 99024. I go back to thinking about how many people had difficulty reporting PQRS when it was PQRI with a 0 charge, right? Folks had to add 1 cent to have it go through to the Medicare program, and as I mentioned earlier, I'm sure we'll see more instructions. Because this will only capture a number of visits and not anything else that would be really helpful in changing the payment system, CMS is going to be adding a survey component to this, right? So that's going to be the more robust component. It'll complement the claims-based reporting, and hopefully the survey will provide CMS with the really resource-based information to be able to determine the actual reimbursement for some of these codes. And because that will give them resources, intensity, etc., and be able to look at one procedure to another rather than just the number of services. To give you an idea of what they're proposing to be in the survey, there'll be 20 post-operative visits furnished to Medicare beneficiaries during the reporting period, which I'm going to assume right now, some transmittal may prove me wrong over the next couple of months, but the reporting period first will be 2017. So it would be what is the procedure code or codes and the date of service that the global period started. What was the place of service? Was it hospital inpatient, hospital outpatient, ambulatory surgical center? Were there any complications? the number and sequence of the follow-up visits, so the follow-up visit that they're requesting the survey data on, right? So it doesn't mean that they're going to request the first visit after when they do the survey. When they choose the sample size, it may not be that it's the first post-op visit that they're asking you about, right? And then they'll massage that data and hopefully be able to come up with more information on the level of visit, the face-to-face and non-face-to-face activities that were also furnished on the day of the visit, how much time is spent, direct practice expenses, items, think about it, are you doing a dressing change, etc. Did your clinical staff need to be involved with the patient, doing vital signs, taking a history? So that's the facts. Having looked at a few charts, a post-op visit is very often a very brief note that may say nothing more than patient here in follow-up for surgery on November 11th, doing well, incision healing, no redness, no signs of infection, patient to return in 3 weeks. Well, that doesn't tell me anything for this survey. So it definitely doesn't tell me how much time was spent. Doesn't tell me whether or not my staff did anything in between. So I would urge you all to start thinking about knowing that this data and reporting 99024 is going to have some impact on your surgical billing reimbursement. One is it that without creating a huge burden for you, could you relatively easily capture starting in January 2017? I say that because I think the alternative is to have very little information that you could support, because obviously they don't want anecdotal data. Then if and when you are chosen for the survey component of this and have that negatively impact the actual reimbursement, right? So because the survey will ask the level of visit if you had been using regular E&M codes, right? Would it have been a level 2 or 3 or level 4 E&M visit? What other activities were furnished that day, the amount of time, and to get to that practice expense component, what kind of supplies, surgical dressings, gloves, etc. were needed. So think about all of that and do indeed watch for more information from CMS and your specialty societies, excuse me, on all of this. So this is going to be interesting and see how that is collected. I gave you a hint as to, or some guidance as to how CMS has targeted the claims reportings. What they figure about 85% of all surgical codes will be reported on with the number of post-op visits. They're looking for a survey target population of about just short of 5,000 practitioners. And you can read this slide. I'm not going to read it all, but that means that to get that response rate, they have to survey close to 10,000 practitioners, knowing that not everybody will respond. So don't be surprised if one of you, that's a fair number of surgeons, someone on this webinar, I have a feeling more than one of you is going to wind up with this survey instrument. And I would urge you to make sure that your staff know to get that to you. I don't even know how it's going to come. I doubt that CMS does now. If it's going to be in the mail, an email with a secure website, I'd actually think it's going to be the latter, but time will tell. And then there's a third component, and they haven't defined this any more than what you see here, direct observation. So then there'll be a few of you who will have the dubious distinction of having someone come on site, a small number of practices that will have external observers to capture the activities conducted in a sample of post-op visits, right? So that is going to be the interesting component of all of this, and no, I have no idea as to how they're going to figure out for what type of surgeries that they want to look at post-op visits. More to come on all of this, but that will be the third component. To wrap up this section, remember I had said this is a required reporting as of July 1, 2017. They can indeed penalize the surgeon, the surgical assist payments, up to a 5% withhold of your payment for the practitioner who fails to report when you have to. So with everything else you guys are worried about, use the first 6 months of the year to get used to recording the 99024 and maybe fluffing up to more accurately represent the amount of work, resources, etc. at those post-op visits. And please don't forget to also be recording your post-op visits at the facility, in the hospital, going back after the surgery while the patient's in the recovery room, to have a visit there, right? I mean, all of those are going to count in the reimbursement, so time to start developing new habits. Knowing that many of you may be in an ACO, the CMS did address this as well and said that a survey of practitioners participating in about 4 to 6 ACOs and will be asked to do the survey, so it'll be interesting. You know, here in Palm Beach County we have a highly successful, the Palm Beach ACO, and because of their success I wonder if they won't be one of the ACOs chosen. So again, more information to come, but definitely going to be an interesting year for the surgeons. All right, let's move on. So this is the fun part of the rule, actually. In fact, when the proposed rule came out and I started reading all of these sections, I felt like I was reading a novel. It's the way CMS was approaching primary care and other cognitive specialties. So here's just something that they said in the proposed rule to kind of set the stage for their approach. In recent years, we have been engaged in an ongoing incremental effort to update and improve the relative value of primary care, care management coordination, and cognitive services within the physician fee schedule by identifying gaps in appropriate payment and coding. These efforts include changes in payment and coding for a broad range of physician fee schedule services, and just as an aside, think about transitional care management, chronic care management. I'm sure that's what they're alluding to. This effort is particularly vital in the context of the forthcoming transition to MIPS and advanced APMs under MACRA. Since MIPS and many APMs will adopt and build on physician fee schedule coding, RVUs and physician fee schedule payment as their foundation. So, all right, they've acknowledged that they've been changing their methodology in how they how they value services. So what were their goals for 2017? To improve payment for care management services provided for patients with behavioral health conditions, something new. Improve payment for cognition and functional assessment and care planning for beneficiaries with cognitive impairment. Sounds like something new there as well, plus an expansion. Adjust payment for routine visits furnished to beneficiaries whose care requires additional resources due to their mobility-related disabilities. Unfortunately, this last one, and I'll show you because I do want to actually mention it for another thought process for you all, isn't going to be in effect in 2017. So what about these goals of improving payment accuracy? What's really tangible based on what I just read to you from the rule? They want to, and they will be recognizing for Medicare payment, additional CPT codes within the chronic care management family of codes for complex chronic care management. In addition to, and those complex chronic care management codes have existed, it's just that Medicare hasn't paid for them, but they will be effective January 1. And CMS has created an add-on code for that quote and end quote initiating visit during which the chronic care management services are initiated, right? So that visit that you have with the patient where you develop that care plan, add-on code to compensate physicians for the time and resources spent in the development of that care plan. And then a whole new area of coding and payment for behavioral health integration services, including substance abuse disorder treatment. Well, that last thing when they added that in the final rule was delightful to read because we'd all have to have our head in the sand if we didn't realize what a epidemic substance abuse has become in this country. And then the shocker of all times for me, as I kept on reading, was their intent and they're going to follow through on, recognizing for Medicare payment non-face-to-face prolonged evaluation and management services. And I was shocked when I read that one. So we'll take a look at a few of these and see what we can get through. All right, so I'm going to start with this one, and you've got a few slides on collaborative care management. I'm not going to read each one only because I haven't yet come across, not with our constituents, my firm's clients, yet anybody who's working in a collaborative chronic care management environment. So this is a new collaborative approach to treating mental health issues, whether they be psychiatric or substance abuse, and it includes services of a psychiatrist. There's also a component of behavioral health integration, a team-based approach to care that focuses on integrative treatment of patients with medical and mental or behavioral health conditions. Now, this as new payable services, next year I might be able to tell you that, oh, I know a whole bunch of people who are doing this now. Let's see who can think outside the box. So just to give you an idea as to what it is, CMS have created some G codes, some HCPCS codes. In the final rule, they were very clear that they are aware that the AMA has developed some new CPT codes that would mirror the definition of these psychiatric collaborative care management G codes, HCPCS codes, but that CMS actually wanted to begin paying for it now, i.e. January 1, 2017, and these CPT codes are not scheduled to come out before 2018. So that's also very interesting. If you really stop and think about it, there are more services being paid on a fee-for-service basis for physicians who have the resources and can take the time to understand and implement them to help them get reimbursed for the services that are necessary if they're going to get paid on value and outcomes, which is a very interesting approach and much more upfront and honest for physicians than I think any of us ever would have expected from CMS. So we have this new G code effective 1/1/17, G0502, which is the initial psychiatric collaborative care management service in a calendar month. It's at least 70 minutes, and you can see all the detail here, but you see it's these behavioral health activities in consultation with a psychiatric consultant, right? So don't know how many of you in a multi-specialty organization are working with a behavioral health organization in your community are doing anything like this collaborative care management, but there's the initial code, then there's a G0503 for subsequent psychiatric collaborative care management, 60 minutes in a subsequent month of behavioral health care manager, and here's all the activities that are included, and then a G0504, which is the monthly, almost like chronic care management, only for mental health and substance abuse issues, right? So think about chronic care management, but in the mental health arena. Some of the nuances for this, briefly, there's something that they're calling a behavioral health care manager, and this individual furnishes the services both face-to-face and non-face-to-face, consulting with the psychiatrist, consultant minimally on a weekly basis. Excuse me, and they do expect that if you've heard about this or if you've been toying with entering this care arena, know that I find this very striking that they say we would expect that the behavioral health care manager would be on site at the location where the treating physician furnishes services to the beneficiary. Why do I point that out? Many of you probably recognize that with chronic care management, there are a plethora of companies out there now who will subcontract with your practice to provide chronic care management. And my instincts tell me that this we would expect sentence from CMS is saying we don't want to see this for the collaborative care management in mental health, behavioral health. We expect the individual who's providing this quote-unquote day-to-day and month-to-month service to actually be a part of the practice and there physically, right? And they go on to say this care manager is a member of the practice's staff, etc., right? So, you know, be careful if the folks who are providing chronic care management don't quite understand this new payment benefit and they start wanting to add behavioral health services to it under this collaborative model. Understand that that's not going to work for this. This has to be your person. All right, so then we have a little bit of a different take that is going to be beneficial for lots of folks. So I'm going to reverse the order on this side, and I'm going to talk about the G0505. You know, Alzheimer's and dementia, I think everybody is recognized as a growing problem as the baby boomer generation, so many of us, age and age for so much longer, right? I mean, it's one of the main reasons to me, even as a non-clinician, why we see so much of this disease process, because folks are just living longer, so we see it more than we would have ever seen before. So the Medicare program is actually going to recognize and pay separately for the physician or non-physician practitioner who documents their assessment and develops a care plan for the patient with cognitive impairment. And CMS particularly references Alzheimer's disease or dementia. And just as with the collaborative care management, they're creating this temporary HCPCS code, G0505, knowing that the AMA has a CPT code planned, but that won't be in place until 2018, and the Medicare program actually wants to start paying earlier. So the definition is cognition and functional assessment using standardized instruments with development of recorded care plan for the patient with cognitive impairment, history obtained from patient and or caregiver by the physician or other qualified healthcare professional in the office or other outpatient setting or home or domiciliary or rest home. Okay, so a couple of things here, obviously. This is not something that you can provide in the hospital setting. This is a community-based home office service. And then, and I apologize for actually having these things reversed. So if you've done the assessment and you're getting paid for doing that assessment and developing a care plan, then we've got G0507, which is the calendar month, just like chronic care management, but now for the cognitively impaired. G0507, care management services for behavioral health conditions, at least 20 minutes of clinical staff time, directed by a physician or other qualified healthcare professional time per calendar month. So whole new area here for chronic care management, but for those who are cognitively impaired. Right? Depending on your practice, that can be a big boon. So in that assessment and care plan development, there are indeed some specifics that have to be performed and documented. Cognition and focused evaluation with a pertinent history and physical exam, medical decision making of moderate or high complexity, a functional assessment, whether it be a basic and instrumental ADL and decision making capacity, use of some standardized instrument to stage dementia, and it's worthwhile noting that the G0505 is payable regardless of the stage of cognitive impairment or the stage of the dementia. So could be early on. It doesn't mean that it's just an end-stage dementia patient. Medication reconciliation, review for high-risk medications, evaluation for any neuropsychiatric behavioral symptoms such as depression, including a standardized instrument, evaluation of safety, say in the home, whether or not the person can continue to drive if that's applicable, who are the caregivers, what are their needs, do they need social support, advanced care planning and addressing any palliative care needs, if applicable and the beneficiary agrees. So my little subnote is that since G0505, the cognitive impairment assessment and care plan development includes ACP advanced care planning, clearly you can't bill the two services on the same date of service. And then of course creation of that care plan, including initial plans to address any neuropsychiatric symptoms, referral to community resources if needed, such as an adult daycare program, support group, even if the support group is for the caregiver or the family members, and obviously that the care plan is shared with the patient and or the caregiver at that initial encounter. So for anybody who's really working with the this patient population, physicians I've spoken to, there's hardly anything here that they're not doing anyway, may not be dressing it in as formalized a manner as the code will require, but excuse me, but this is a whole new service. That evaluation, as opposed to the monthly care plan management, must be personally performed by the physician or non-physician practitioner. There are a few services that cannot be billed on the same day because we're dealing with cognitive issues. The psychiatric codes that are listed on this slide cannot be billed. It can also not be billed with an outpatient evaluation and management service. So it's not an add-on code, it is the code, right? So it's expected that that's all that's done today. And as I'd mentioned, no advanced care planning or any other kind of care planning activities such as care plan oversight, etc., can be performed on the same day. And something tells me that as extensive as the assessment and development of the dementia Alzheimer's patient typically is, that there's no way the physician or non-physician practitioner is going to be able to provide any of these, or want to, on the same day, nor would the patient be up to it anyway, right? To give you an idea as to what it's going to pay, so the RVUs that were proposed showed that, and I apologize I didn't go into the final rule to look, but I think it actually went up a little bit, that the G0505 is going to pay about $245 to $250, not adjusted geographically. And just to give you a feel for, okay, what is that in relation to other codes, a new patient office visit, level 5, that highest level for a highly complex patient in the proposed rule was about, and again, not adjusted geographically, $225. So it's expected that this will pay better than the highest level new patient office visit. So it sounds like CMS really anticipated the degree of physician work, the amount of resources from a cognitive and time perspective to pay for this appropriately. And then, excuse me, there is another add-on code though. This is for your chronic care management and for anybody who is going to enter into or is already providing collaborative care management. This G0506 is an add-on code. This is the code to be billed during the initiating visit. Let's just discuss chronic care management for a moment. That initiating visit where you're seeing the patient and patients agreed to chronic care management, you develop the care plan with its goals, etc. This will be an additional code, G0506, that can be billed effective January 1, 2017. I'm going to talk a little bit more about that in a minute. So this was one of the disappointing things as they were trying to add services to increase the payment accuracy. CMS had proposed creating and paying for a new HCPCS code G0501 to compensate physicians for the additional resources they would have expended for seeing a patient who has mobility disabilities, right, that special table or chair, etc. And as I had looked at the proposed rule, it looked like, and this would have been an add-on code to your visit code or other service today in the office, it looked like it was going to pay approximately about $50, oh goodness, $50 extra, right? And then in the final rule, they made it really clear that for a lot of reasons, they were putting it on hold until perhaps 2018. The reason that I am still keeping it in my slide is that this is what was in the final rule. We recognize that some physician practices may frequently furnish services to particular populations for which the relative resource costs are similarly systematically undervalued, and we seek comment regarding other circumstances where these dynamics can be discreetly observed. Well, the final rule may have come out last month in November. You still have time to comment on it. So this is why I bring this up. Know that CMS seems to be open, very open, to actually reimbursing physicians for those extra things, that extra expense that you may have gone through to be able to provide high quality and accessible care to your patients. While they, for many reasons, are not going to pay this mobility impaired disability code in 2017, they are still open to other ideas for services that might indeed, or costs you might have to incur that are beyond what was originally contemplated. So for me, I think about that Section 1557 of the Affordable Care Act. You know, that whole thing that you've had to worry about over the last month for having special policies in place, taglines, and disclosure statements for your non-English speaking patients, whether they need a Spanish, Creole, Portuguese interpreter, or it's the hearing impaired and you need to bring in a sign language interpreter, etc. Those services add such an additional expense that very often the cost of the interpreter is greater than the physician or non-physician practitioner is going to get reimbursed for the service they're providing. So I bring this up if there are any advocates for themselves here on this webinar, or for you to go to your specialty organizations and ask maybe they could be your advocate. Why not, since CMS is clearly open to the idea, why not take this opportunity and use it to see if they wouldn't consider reimbursing the physician practice or other organization for the costs of interpreters, translators for documents, etc., especially now that we have additional requirements under Section 1557 of the ACA. So forgive me, but that's just my little physician advocate piece during today. All right, so another little change that, before I get into some of the chronic care management that I probably should have stated earlier, is about physician supervision. Remember when transitional care management first came out and then chronic care management, one of the things that CMS did was to say, after they'd first started paying for it, they came back and they went, let's revise our payment policies a little bit because it doesn't make sense for us to require direct supervision for incident to services, since these chronic care management services, part of the transitional care management services, are provided by clinical staff. The access isn't going to be there for the patients that they wanted if they had to, if the practice had to provide the direct supervision, i.e. physician in the office suite right there with the clinical staff member at the time services are rendered. So they keep making exceptions for and stating that, okay, no transitional care management, we're going to make an exception to incident to, we're just going to require general supervision, and the same thing for chronic care management. So that they do not have to keep making exceptions, they are changing the rules this starting in 2017. They're going to actually state that for the supervision of non-face-to-face care management service, certain designated care management services, that they will designate those services as only requiring general supervision. So even as they added some of the new codes, like the Behavioral Health Care Management Code with the Dementia Alzheimer's Care Planning Code for 2017, they're automatically just stating that those codes fall under the category of a designated care management service, which automatically then means that those services, any codes in that service category, only requires general supervision. All right, let me look at for you the non-face-to-face prolonged services. Now, these are codes that have been in the CPT book for eons. Nothing new. And physicians have often groused, and understandably so, I don't mean that word in a negative context, groused that, oh my God, I get all these records, or I spend so much time speaking to the patient or family member or the patient's physician before I ever see the patient or after they've left, and I get all this information, and there's no way for me to get paid for it. It's bundled into my visit code. Well, starting next year, quote, separate payment for existing codes describing prolonged evaluation and management services without direct patient contact by the physician, and increased payment for prolonged E&M services with direct patient contact by the physician, because they're adopting certain RUC committee values, which it's this non-face-to-face that to me is, oh my gosh, you're kidding, right? So just a moment on the face-to-face. So in the office, the first hour of prolonged evaluation and management services face-to-face with the patient with direct patient care, 99354, they have almost doubled the RVU value of that. So suddenly that becomes a much more I don't want to say it wrong, a much more enticing code for you to remember what the documentation requirements are so that you can bill and collect for face-to-face prolonged services with the patients in your office. But the best news is the addition of these two codes for payment in the Medicare program. They're both add-on codes, 99358 and 99359, so they, you know, if you've never seen the patient, obviously you're not going to bill these. So 99358, prolonged evaluation and management service before and or after direct patient care first hour. Not adjusted geographically, reimbursement, Medicare allowable, approximately $118. 99359 is the same service, but each additional 30 minutes. So this would be billed in addition to 99358, approximately $57. Right? And CMS is stating this is a means to recognize the additional resource costs of physicians and other practitioners when they spend an extraordinary amount of time outside the in-person office visit caring for the individual needs of their patients. Beginning in calendar year 2017, we propose to recognize these codes. We note that time could not be counted more than once towards the provision of 99358 or 99359 and any other physician fee schedule service. So because they've made this specific reference to basically don't double dip that hour, I think that your documentation is going to be critical. Now, if you're providing the non-face-to-face prolonged services on a date prior to or subsequent to the actual visit, say office visit, that clearly it's easy not to, for your record to support that there was no other service that was occurring during that same time period. But knowing that CMS for face-to-face prolonged services requires as part of the documentation that the clinician document from and to in and out times, although they haven't said it yet for this, and again I expect to see transmittals, MedLearn Matters articles from CMS to further clarify. If it was me, I would start off documenting 11:05, right, a.m. and then whatever records I was reviewing, my summary, if I spoke to the physician at Cleveland Clinic for clarification, and then ended it with the time, right? And plus, knowing that you could potentially have that first hour, which is what has to happen for 99358 to be billable, that first hour not happen in 1 hour's chunk. It's probably a lot easier in the long run to have documented start and stop from and to times, so that when you're completed you can go back and look and go, oh yeah, that was 1 hour and 10 minutes. Yep, I get to bill 99358. So CMS goes on, though, we agreed that these codes would provide a means to recognize the additional resource costs of physicians and other billing practitioners when they spend an extraordinary amount of time outside of an E&M visit performing work that is related to that visit and does not involve direct patient contact. And then there are examples such as extensive medical record review, review of diagnostic test results, or other ongoing care management work. Now, obviously that other ongoing care management work, as an example of the Medicare programs, is probably why they state above, basically, please don't charge the same amount of time for two different codes. I wish they hadn't said care management, because you start thinking about some of the other codes I've already referenced today, right? And clearly this has to be distinct and separate from that. They are going to conform with CPT guidance, which is important, because initially when they had this in the proposed fee schedule rule, they were only going to pay for non-face-to-face prolonged services that happened on the same day as a visit, which was crazy, because you get the records ahead of time, especially if you're a specialist, right? Or if the patient has transferred their primary care from another physician, whether locally or from another part of the U.S. or out of the country, you might indeed have those records a day, a week before, right? And gone through them in preparation for your actual face-to-face visit. So they did correct that in the final rule and clearly stated that we're going to follow CPT guidance, right? So they're going to pay separately, and notice though that they keep saying extended time and extraordinary amount of time, etc. So I kept looking, knowing that CPT codes say that to bill for a time-based code, a code that you can't bill without time, i.e. prolonged services. What's the rule? When do you have enough time spent to bill that code? In the introduction section of the CPT book, it's really clear. It states something along the lines of when the midway point has been passed, right? So that would tell me that at 31 minutes, I could bill 9 358. So far, in the rule, CMS is saying that 9 358 is payable at an hour. So I've already given thought, and maybe saying it out loud now will remind me to comment to them to make up their minds. Are they following CPT conventions, or is it a minimum of an hour? So like with some other things, please make sure that you look out for further explanations through transmittals, CMS webinars, MedLearn Matters articles, things posted to your Max website, etc. Right? So, yeah, and so this will be real interesting, right, to see. But this is an opportunity for doctors that never existed before. So let's go back to the care management assessment and plan codes, because the rule here. Sorry, let me go back to the non-face-to-face. They say when it comes to transitional care management, chronic care management, we note that while these typical times assigned to transitional or chronic care management, are not required to bill the displayed codes, we would expect that only time spent in excess of these codes would be reported. So in other words, okay, if you're going to bill transitional care management, which is not a time-based code, yeah, you can bill prolonged services if indeed you have this extraordinary time in addition to the TCM, etc. But what the heck is the time if you have to spend all of that time? So in the file of codes with the fee schedule rule, the narrative, I actually realized I had a whole file this year that showed what the anticipated or typical times were for the codes. So that cognitive impairment assessment and plan, that G0505 for the dementia Alzheimer's patient, that is paying better than a 99205, they assume that's going to take you about 85 minutes. And it can indeed be a companion code for non-face-to-face prolonged services, which is great because a lot of the work that you would be doing in assessing the dementia Alzheimer's patient, I am sure with records and assessing assessment tools, etc., is going to be done non-face-to-face. And then the new G code, the add-on code for chronic care management, G0506. Remember, this is the code that if you're seeing the patient for their annual wellness visit or an office visit today, and you discuss with the patient chronic care management, patient agrees, and you develop the care plan while the patient is there, that you would be able to build G0506 in addition to your E&M code, right? So that has about 28.5 minutes attached to it. And so I found that also very interesting. And what they say for clarification, because one of the hardest things for me reading this was, oh my gosh, what codes can be billed with what codes? The italicized wording here is from CMS, in association with the chronic care management initiating visit, i.e. G0506, a billing practitioner may choose to report either prolonged services or G0506 if requirements to bill both are met, but cannot report both a prolonged service code and G0506. So think about it. You have your visit, and you've also done all of this assessment work. You get to choose. If you've only spent, let's say, 29 minutes or less towards the chronic care management assessment and care plan development, you bill the G0506 plus whatever your office visit or annual wellness preventive service code was. If you've spent an hour or more outside, including time outside of the patient, so that you could have met also one of the, say, 9358, the non-face-to-face prolonged services code, you have to choose. You can't bill them both. And they're actually giving you the ability to bill the one that is most advantageous to the physician. All right, so I've mentioned chronic care management a fair amount. I'm here to tell you that there are some changes in a positive way in 2017. CMS looked at the utilization of 99490 in calendar year 2015 and felt that it's underutilized. Only at the time of the publishing of the final fee schedule rule, only about 500,000 Medicare beneficiaries had ever received chronic care management out of the millions and millions of Medicare beneficiaries. And for those folks, they only ever received it for 4 different months, 4 times each. And CMS really knows that this is a patient population, those with 2 or more chronic diseases, that benefit in so many ways, including lowering Medicare costs, by having someone stay on top of their conditions, their medications, etc. So along with their goal for access to advanced primary health care to support patients with chronic diseases to achieve health goals, they are minimizing the Medicare rules for payment of chronic care management. And on top of that, they're also going to start paying come January for complex chronic care management. CPT codes 99487 and 8960, and each additional 30 minutes of clinical staff time. Remember, 99490 is 20 minutes, right, of chronic care management. If the patient actually had, an hour and a half or even an hour's worth of chronic care management with your clinical staff during the course of the month, you didn't get to bill more than just 99490. Now, if it's 60 minutes minimally, instead of 99490, you'd be able to bill 99487. Obviously, all of this depends on having the right clinical documentation, but, excuse me, and in that regard, they are definitely expanding the scope of chronic care management. And in these particular codes, they are definitely not following CPT code rules. There is nothing in the CMS rule that says anything other than that they're requiring that the number of minutes in the code definition be the baseline number of minutes that were spent. So complex chronic care management 99487, the documentation must support minimally 60 minutes that month, not 35, not 50 minutes, but 60 minutes, etc. So on this slide and the next one, you have the definition, what is in the complex chronic care management codes, and the approximate reimbursement. So if you think about 99490 for that 20 minutes, it's what, $42. 99487 will be a little more than twice that. In the outpatient setting, $96.47. And when I looked on the fee schedule, I could see that there was even an inpatient fee, which I'm not quite certain, But I guess if you don't go see the patient in the facility, you can still bill chronic care management. It was an interesting thing. I'm not quite sure why they would even say that for the complex chronic care management, that there was an inpatient allowable. So again, before you start thinking that you can bill chronic care management in the inpatient setting, complex chronic care management in the inpatient setting, I'd be looking for that Transmittal or Midland Matters article for sure. And then of course 99489 is just the each additional 30 minutes, so you would bill it on in addition to 99487 in the course of a month, and without adjusting it geographically, about $49 is the average reimbursement. Now I'm going to show you Table 11 in a moment, which are the new requirements for chronic care management for 2017. And you'll see that some of the reporting requirements that exist today and will through December 31st are gone come January. The main difference in the three codes is the amount of time that your clinical staff actually performs, provides, and documents, the complexity of the medical decision-making, and the nature of the care planning that was performed. To bill 99487 or 889, the definition, well, let me go back up. For 99490, the definition includes establishment or substantial revision of the care plan. For 99487 and did I mix this up? Nope. Or 89, establishment, implementation, revision, or monitoring of the care plan. Oh no, I did mix it up. So forgive me. Establishment or substantial revision of the care plan for complex chronic care management, and yet only establishment, implementation, revision, or monitoring of the care plan for non-complex. So you could actually have just monitoring for 99490, no changes. So they actually are going to expect that for you to be billing 99487, there should have been some change that calendar month. And do think about it this way. It doesn't mean that you bill every month 99490 or every month you bill just 99487. Patient might come out of the hospital, finish transitional care management, and the first month have 99487 with or without 99489 for the amount of time spent by your clinical staff. And then the following month, maybe just 99487, now the patient's doing better, you're just kind of monitoring that care plan with the patient. Maybe now the next 6 months it's 99490 each month. I wouldn't expect that there'll be an all or nothing type approach with these codes over time. And as you stop to consider which patients might qualify, think about the number of illnesses, the scope and complexity of medications. Has the patient been admitted anywhere, had to go to the ED since your last billing of chronic care management? As you think about, well, what's the difference in the medical decision-making between chronic care management and complex chronic care management? And please, if you're doing this, do not forget about CPT code HCPCS code G0506, that new face-to-face visit code that is when you develop the care plan and initiate chronic or complex chronic care management with the individual. So, excuse me, you can bill the G0506 at a Welcome to Medicare physical, that initial preventive physical exam, or an annual wellness visit, or an E&M visit. What's interesting is that CMS has clarified for 2017 the fact that the visit at which you initiate chronic care management doesn't have to be a, quote, comprehensive, end quote, visit. So it could be a level 2 through a level 5 E&M visit. And it again states that a nurse visit, that 99211, does not qualify. So if you had 99211 on December 6th and G0506 with a date of service of November 6th or December 6th, you would not get paid for the G0506. Here's the definition of that code. I wouldn't expect that anybody signs up, so to speak, a new patient to chronic care management without billing this. It's going to pay, remember now, in addition to your service, approximately $66. So it's actually decent reimbursement. and they state the following. We believe G0506 might be particularly appropriate to bill when the initiating visit is a less complex visit, such as a level 2 or 3, although G0506 could be billed along with higher level visits if the billing practitioner's effort and time exceeded the usual effort described by the initiating visit code. So pretty much, again, think about it. Be visual. Does the documentation for, let's say, a 99214, if I cut all of that out, right, everything that I believe supports that level 4 established patient visit, do I have enough documentation left to support the definition you see in front of you for G0506? If yes, then no problem. It's an add-on code, and it's only used once. So if you're changing the chronic care management code, if the patient drops off, goes up north again, right? So in the summertime and you see the patient again in the fall, you do not get to bill another G0506. It's basically per physician, per nurse practitioner, PA, etc. It's almost like a once in a lifetime per patient for you. There's no reinitiation of chronic care management. Let me see. There are changes that in the care plan that the same requirements for the care plan in the monthly chronic care management codes as this initiating visit needs to be electronic in your EMR, patient-centered, that you've done an assessment, inventory of resources and support the patient might needs, and that you're encompassing all the patient's health issues, even if you're not treating everyone, right? You may be the patient's, say, primary care physician, but the endocrinologist is treating the diabetes because it's been out of control or has complications. So the care plan and its goal might be to follow up with the endocrinologist and to maintain a hemoglobin A1C, let's say for this particular patient below 7. So how your clinical staff would work with that patient on a month-to-month basis is to maybe get this hemoglobin A1C, the last results from the endocrinologist, etc. Right? So make sure you're quote-unquote managing everything, but you're not necessarily treating it. I'm actually, for time constraints, not going to bring up Table 11 as I look at my watch, but it is a second attachment for you here, and it lists the requirements that chronic care management will have effective January 1, 2017, and you'll see that they have lessened several things, such as there'll no longer be a requirement for a patient to be given and sign a consent form. Instead, they're stating that just make sure that you've documented in your clinical record that the patient was explained what chronic care management is, that they understand that there's a copay and coinsurance, that they understand that only one clinician can provide the service, etc. Right? And there are some other things that you'll see there. So that's why we've included it. All right, before I get into some kind of more reimbursement changes and rules, if you look at this slide, these are all the types of services that are either non-face-to-face or have a non-face-to-face component that will exist come January 1, 2017. Now, transitional care management, 99495 and 96 have been around since 2013, 99490 since 2015. Last code on the left side, 99497, advanced care planning this year, and yes, that must be face-to-face, but the patient isn't able to participate in a discussion about advanced care planning. It allows that the family or caregiver is the individual that you're with, so there's a non-patient perspective there. We've now added below 99490 complex chronic care management. We have initiating codes for care plan development for the cognitively impaired patient, for the patient with 2 or more chronic illnesses. We've got non-face-to-face chronic care management, non-face-to-face prolonged service codes. We have the cognitively impaired monthly chronic care management codes. This is all within the last 2 or 3 years. Additional payable codes, as CMS kind of puts its money where its mouth is to let you know, as the physician community and non-physician practitioners, okay, there is indeed a cost saving and quality improvement when physicians are allowed, my words, not CMS's, to provide services that are not the typical face-to-face, just what you did while you were with the patient services, that decrease hospitalizations, decrease emergency department encounters, decrease complications, and consequently add to the quality of care of the Medicare beneficiaries and decrease overall costs. And we, CMS, the Medicare program, we're acknowledging that, and we're willing to pay you doctors for it, right? So that's really quite a change. It was striking to me to make this list. All right, in my last couple of minutes, a couple of reminders and payment changes. Well, one, you have a new conversion factor come January, $35 and basically 89 cents, up a little bit from 2016. So why do I bring this up? Some of your managed care contracts may indeed be based on the quote-unquote current conversion factor. Since it's gone up, you need to check your managed care contracts to make sure that your fees go up as well for those plans in 2017. So please, sometime over the next 2 to 3 weeks, pull out your managed care contracts or your grid, however you keep maybe the information in one central place, and see which payers that you have contracts with include the Medicare conversion factor in their fee schedule and how they pay for your services and items, so that you can watch out for increased payments in 2017 and hold the managed care plans to the fire for their contractual obligations. For any of you who are doing traditional x-rays in your office and still have film, it is required effective January 1 that any x-rays that are taken and billed to the Medicare program using film, the code that you bill must have modifier FX, Frank X-ray, attached to it. Example 71020FX. The use of the modifier will result in a 20% reduction of the technical component of the service, not the entire service, the technical component. And CMS is looking at this as a payment incentive. You see my question mark. And what they say is the legislation which is the Affordable Care Act, does not authorize any financial incentive in the form of increased payment, but provides an incentive to use digital images to avoid the 20% reduction that applies to imaging services that are x-rays taken using film. So the incentive is upgrade your equipment so that you avoid the penalty. And there is indeed a MedLearn Matters article out already on this, so I've given you the MM9727 reference here. If you go to cms.gov, and for these payment changes, you'll just put the MM number or SE number that I've got on the slide in the CMS search box to come up with that article. And good news for folks doing imaging. Remember, a couple of years ago, the CMS implemented a multiple procedure payment reduction of 25% on the professional component of advanced imaging, so CT, MRI, PET scans, and some others, and for multiple imaging procedures furnished in the same group, same practice, same imaging center on the same day. That is going down to a -5% come January 1. So that's some good news. Right? We have basically a 20% increase in the professional component payment. For any of you who are providing clinical laboratory services in your office, where you have, whether it's waived or moderately or highly complex lab, you may have to report the amount of money that you are paid by commercial plans if, and only if, so who qualifies, you receive greater than 50% of your total Medicare revenues from the clinical lab fee schedule or the Medicare Part B fee schedule, and at least $12,500 of that revenue is only for clinical lab services during the six-month data collection period. So I guess if you looked at last year's clinical lab, any code starting with an 8, and how much of it was Medicare revenue, if it was $25,000 for the year, you know you're going to have to report. So what's reported? It's not by individual, it's by the tax ID number, and you will need to report private payer rate information for all of your clinical lab services. Why? So the weighted median private payer rate will be the new clinical lab fee schedule payment rate for most clinical lab services furnished on and after January 1, 2018. Guess what? Medicare decided they may be paying more than the managed care plans are paying, and they're going to cut back. There is a fact sheet noted at the bottom of this slide that you can find more information on this if you are indeed providing and billing for lab services in your practice. Just in the cms.gov search bar, put ICN 006818, and you'll come up with more information. When's the first data collection period? Well, they're going to look at the payment by private payers in the first 6 months of 2016. So from January through March of 2017, if you qualify for reporting, you'll be asked to report the HCPCS code for each test that you billed and got paid for by Medicare, the final payment rate that was paid by each private payer for that test, and by final payment rate, they mean total from a primary and a secondary, and what's the associated volume for each test. So if you did SED rates, 85651, I think, did you do 100 of them, 1,000 of them? What's the volume? And at least this isn't an ongoing reporting, since it's going to have like about a 2-year lag for impacting fee schedules. The 2016 data will be reported in the first 3 months of 2017, and then not again for another 3 years. So during for the rest of this year, so that you know whether or not within the first 3 months of next year you need to report, you need to look back at the information, the volume of your Medicare revenue, and what the amount in dollars, $12,500. Did you have $12,500 in Medicare revenue for lab services between January 1 and June 30th of this calendar year? And if so, then you'll be someone who will have to report. Make sure that you review and validate the information before it's reported to CMS. The last thing you want is to find out that, oh shoot, we reported something wrong, right? So you have some time to do that. There's an email address I found for inquiries should you have questions, clfs_inquiries@cms.hhs.gov. And so what could you do now? Confirm your enrollment data in PACOS. Make sure that they show you correctly. When you do that, identify who will submit your data if you've already determined that you'll have to submit, and who will certify your data. So you have 2 individuals who are supposed to register in the EIDM CMS portal, which is the same place you should be going to get your PQRS reports for 2015, your quality resource and resource reports, your QRUR. It's the same area, that same CMS portal, but you need to be thinking about this now, right? Because you want, 1, to find out whether or not you have to report. So did I have most of my revenue through Medicare Part B and clinical lab? 2, if so, did I have at least $12,500 in clinical lab reimbursement in the first 6 months of 2016? If yes, I need to make sure that I'm set up correctly in PACOS, my tax ID number, that the right people are registered in the CMS portal to submit the data, and let me look at my payment rates, etc. I don't know that you're going to be able to run an easy report that gives CMS the information that you're going to have to submit to them. So give yourself some time to do that. Physical and occupational therapists, here are your new codes. You have 3 new evaluation codes based on complexity and the amount of time that you spent with the patients. That's the PT. Here's the OT codes. I don't know, it's too early to know what the commercial and other plans are going to do, but the Medicare program is going to pay each of the new codes at just 1 rate. They're going to use 2017 to collect data on utilization before they decide to pay a different rate for the different levels of therapy evaluation. So I've given you an idea for physical and occupational therapy as to what your reimbursement might look like, just to look at the left briefly. If you're a physical therapist, you're 97001 this year. Again, not adjusted geographically. The allowable has been about $77.80, a re-eval about $43.39. Each of the three new initial evaluation codes next year will be paid a little more, $88.40, and a re-eval a little more, $60.28, etc. This is going to take a whole new change in templates, data that is asked of the patients, the evaluations, because if you look at the therapists and their supervisors look at the code definitions, it's really very different than the existing evaluation and re-evaluation codes. I know here we're already revising our chart review tools for therapy and rehab services so that we'll be ready come January 1. CMS went through a whole rationale that you've got here as to basically why they're not paying for the different codes now. They're actually, to sum it up, they're not quite sure what it all means, right? Which is a good thing, I guess, right? So they're going to give therapists time to be educated, adopt the new requirements, have their specialty societies, educate them. And I went up on the APTA's website, and it indeed has acknowledged that it's supposed to be educating physical therapists on the new requirements. So good for the Medicare program. They're actually going to give therapists a year to get these new codes under their belt and change how they document and do their evaluations before it impacts their payments. Understand, however, that all the coverage rules for Medicare apply regardless of the codes. You're going to have to look to your managed care plans to see how this is going to impact your contracted rates. What about workers' compensation in your state? Here in Florida, it takes a vote of Congress to change the codes that are used. So therapists in Florida will probably be billing the old current eval and re-eval codes to Florida workers' comp for a few years, and then see how it all works out. I would be looking at bell curving, just like doctors have done for their visits, bell curving my PT and OT evaluation codes after the first few months, looking to see if I seem to have a therapist in my organization who's quote-unquote upcoding, because that individual might be a compliance risk, or am I losing revenue because someone else in my organization is just routinely inputting the lower evaluation codes just to avoid maybe being a target of an audit. Since CMS has again and again this calendar year stressed this, I would be remiss if I didn't as well. You've got a slide or two on it, but I'm going to make it as clear as I can possibly make it. If you see a patient, you're a Medicare Part B provider, and you see a patient who has Medicaid in addition to their Medicare, whether that be straight Medicaid, whether that be a Medicaid Advantage plan, whether the patient have a Medicare Advantage plan in addition to Medicaid, doesn't matter. If you see an individual who has Medicaid of any sort as a secondary, whether or not you are enrolled in the Medicaid program, do not ask that patient for any cost sharing, any financial responsibility. No deductible, no coinsurance, no copayment. No matter how you ask the question, but I'm not enrolled in the Medicaid program. They don't care. It doesn't matter, and makes me very nervous that CMS has no less than 4 times this calendar year published something on this. And recently they also published a quote-unquote letter to providers that CMS gave to the MACs for the MACs to send out to providers who they find out are actually billing Medicare beneficiaries who also have Medicaid for any amounts of monies not covered by Medicare. This is becoming a very serious issue, and it doesn't just mean that you'd have to pay money back. My last little bullet on this, Medicare providers who violate these billing prohibitions are violating their Medicare provider agreement and may be subject to sanctions, including expulsion from the Medicare program. So please make sure that everybody in your billing department understands that if a patient has Medicare, regardless of what kind of Medicare, and Medicaid is a secondary, regardless of what kind of Medicaid, and regardless of whether or not you have ever enrolled in the Medicaid program. Doesn't matter. You cannot bill that patient for what Medicaid doesn't pay. Period, end of story. I'm often asked, or one of my colleagues is, about should we set up a separate tax ID number? We want to have a separate practice that goes down this little different path. And I believe in the KISS concept, keeping it simple most times, except Medicare has now made it really clear that if one provider has a financial obligation to the Medicare program, and the NPI they work for, maybe a group practice, right, or a division of hospital, is under the same tax ID number, that the Medicare program can reach into any component of that tax ID number and recoup the money. So this little slide is to just say to you that if you're thinking about setting up a quote-unquote new practice, new line of business, I've changed my tune. Maybe you should indeed think about setting up a separate tax ID number so you don't find yourself inadvertently having one component of your business paying for the mistakes of another. Obviously, it needs a lot more discussion than that, but just food for thought. And I think this is probably the last thing. I've often wondered, and maybe some of you have, especially anybody who has appealed charges to Medicare for the physician or other provider they work with, and wondered, what does it mean when they say in the response that the provider is assumed to be financially liable? So Medicare, and there's the MedLearn Matters article that you could go look it up, has made it very clear now that, quote, contractors will presume you knew about a Medicare policy or rule if the policy or rule is in the provider, physician, or supplier manual or in federal regulations. The CMS or a CMS contractor provided general notice to the medical community regarding the policy or rule, so anything that they might post to their website. CMS, a CMS contractor, or the Office of the Inspector General gave written notice of the policy or rule to the particular provider, physician, or supplier. So those denials that you get, those ADRs that you get in the response, you're on notice. The provider, physician, or supplier was previously investigated or audited as a result of not following the policy or rule. The provider, physician, or supplier previously agreed to a corporate integrity agreement as a result of not following the policy or rule. Was previously informed that its claims had been reviewed or denied as a result of the claims not meeting certain Medicare requirements which are related to the policy or rule, or you previously received documented training or outreach from CMS for one of its contractors related to the same policy or rule. Wow. In other words, if Medicare has it written anywhere, you are expected to have known. For me, this is a precursor, again, of some other action that I am not prescient enough to be able to foresee. But this is about as clear as you can get. It makes it that much more important that everybody who should be getting their e-news from their Medicare contractor needs to be getting it and actually looking through it. I know sometimes the titles of articles are not as explanatory as one might like, but we got to do our best. I think this is the last thing. The Social Security numbers are finally going to start going away from the Medicare cards. This is going to be a big deal. Think about when we got NPIs and got rid of UPINs. So by April 2019, there will be no Social Security numbers for any Medicare beneficiary. There'll be a randomly generated 11-character ID. That'll be numbers and uppercase letters only. Every Medicare beneficiary will start receiving a new Medicare card sometime by April of 2018. I bring it up now because just like with the NPI change from UPINs, you're going to need time to think about the system changes, intake forms, billing software, EMRs, etc. And I've given you the URL to find out more information. And then just finally, I used the final fee schedule rule in developing this presentation. As I stated at the beginning, keep on the alert for transmittals, change requests, MedLearn Matters articles, webinars from your MAC, etc., to further refine the coverage criteria. Not much, but some of what I've said is my interpretation, and I can't guarantee you until I've seen more information from CMS that I'm spot on all of it right now. I know I went over a little bit, so no time for questions. Thank God we warned you about that. I will indeed, over the next few days, get to answering any questions you had. Thank you so very much. Mary Catherine, you have any final anything here?
Thank you, Jean. We just would like to thank everyone again for joining us today and hope you'll join us for future webinars. Again, if you do have any questions, please feel free to submit them to us via the questions box or feel free to send us an email. And for more information about future events or other services, please visit our website at www.acevedoconsultinginc.com. Thank you very much, everyone, and have a spectacular day.